So I'm going to kind of talk about the non-spine pathology that we encounter in taking care of children, cover some of the unique pathology that we see, and then talk a little bit about the history and management of clubfoot deformity, which is a very common condition that presents in our population. So I do work for Shriners Hospital for Children. This is a healthcare system in North America. This was established over 100 years ago. And we provide care primarily for children with orthopedic conditions, burn care, spinal cord injury, and cleft lip and palate deformities. Our mission is threefold. We're all about patient care and providing state-of-the-art care for children with primarily pediatric orthopedic needs. Our second goal is to perform clinical research, which we hope improves our care to not only our children, but also the generations that follow us in the medical field. And then providing medical education to medical students, nursing students, therapy students, and whoever can benefit from education in our hospitals. One of the unique things about Shriners Hospital is that our care is provided regardless of the patient's ability to pay. And so if you have a child who is unfunded, uninsured, does not matter. We're happy to take care of them and provide all their care for their needs. We take care of children anywhere from birth up to age 18. If they're in a system, we can take care of them a little bit longer until age 21. This is our hospital in Greenville, South Carolina, down in the south part of the United States, and this is our medical team at our Greenville hospital. So pediatric orthopedic surgery is a subspecialization of orthopedic surgery. We treat musculoskeletal problems in children from ages early newborns up to teenagers and young adults. The deformities can come in different varieties. Some of them are congenital, meaning they're present at birth, or they may develop deformities or conditions during their growing years. The common things that we see involve the limbs. They may involve the spine. They can involve the gait, walking challenges for these children. We do see trauma and fractures in the pediatric population, which are unique from adult fractures. And then occasionally we'll see bone and joint infections or tumors that need to be addressed as well. To become a pediatric orthopedic surgeon, you may know this, it requires typically in the States a 4-year undergraduate degree. Many of our doctors get degrees in basically science majors, sometimes the arts. You then complete a 4-year medical degree where you're given a Doctor of Medicine degree. General orthopedic training requires 5 years of orthopedic residency. And that gives us exposure to all the different fields of orthopedic surgery. And then to become a pediatric orthopedic surgeon, you have to do an additional year of fellowship training. Some are now doing 2 and 3 years of additional training after pediatrics to become subspecialized in particular areas of pediatric orthopedics. You can get subspecialization in hand or upper extremity conditions, spine, hip preservation, sports medicine, limb deficiency, CP, or other unique populations. So many of us kind of develop niche populations that we take care of and develop some expertise in. So just to kind of give you a flavor of some of the unique pathology and conditions that we see in pediatric orthopedics, this is polydactyly. It's a condition where you have extra digits. It's a congenital deformity. Sometimes it involves the thumb, as the picture on the left there. You can have thumb polydactyly. Sometimes it involves the postaxial border of the hand. These are fairly predictable corrections. Usually it involves surgical ablation of the extra digit. With the thumb polydactyly, there's particular care to reconstruct the ligamentous structures of the thumb. Otherwise, you'll be left with some instability of the metacarpophalangeal joint, which is not a good situation. These are pretty common. The postaxial polydactylies are very prevalent in the dark-skinned population, our African-American population. When it's in the Caucasian population, you need to kind of look for some other conditions or other contributing factors. We also see polydactyly in the foot. We kind of classify these based on the position of the polydactyly. If it's on the inside border of the foot, we call that a preaxial polydactyly. When it's on the outside border of the foot, we call that a postaxial polydactyly. And then when it's a duplication in the central rays, we call that a central duplication. The postaxial polydactylies, again, are fairly common. The preaxial and the central polydactylies are not very common. The most rare one of these is the central polydactylies, and we had a chief of staff at our hospital that years ago developed a method for correcting the central polydactylies, and that's called a plantar advancement flap. And that was a technique that he developed where we would retain the great toe and then resect the central digits and then tether the skin around the great toe, bring the toe in to close the gap, and it's worked out very well for these children. Syndactyly is where the fingers are joined with either skin or bone. This can be classified as simple or complex. If it involves bone, we call that complex. It can be partial or complete. So if it's just partial connection of the fingers, that's obviously partial. If it goes out to the tips of the fingers, we call that a complete syndactyly. These tend to run in families. We do see a genetic preponderance of these. The surgery can be performed typically after age 1, and it involves use of specific flaps to recreate the web space or the web commissure. The zigzag incisions allow for coverage of one of the digits with intact skin. And if you know your geometry and you measure circumference of the digits and then you separate the digits, then there's not enough skin typically to cover both digits after you separate them. And so it often requires use of a full thickness skin graft. And that graft can be taken from the groin, from the antecubital fossa, different areas to provide coverage of both digits. The key is to separate the digits adequately and recreate the web space without any significant scarring. If you get scarring, then growth of the finger leads to web creep and kind of recurrence of the syndactyly, and oftentimes that requires another surgery years later. We also see some very interesting conditions involving deficiency of certain bones. So for example, this is a condition of fibular deficiency. The fibula is a small bone in the leg, tibia is the large bone. The fibula is absent in this case on both sides, and when you have absence of the fibula, it tends to involve foot deformity, ankle deformity, as well as some proximal conditions such as absence of the anterior cruciate ligament in the knee. There can be some lateral condylar hypoplasia, which leads to genu valgum. You can see shortening of the femur, some acetabular dysplasia. So it involves the entire extremity, but its most pronounced deformity is in the tibia and the fibula. And you can see how challenging it is. This child, he's walking on the inside border of her foot. This is not a good condition to leave alone. There's options for treatment. Sometimes if the deficiencies are manageable with reconstruction, you can do surgeries to reposition the foot and lengthen the bones and straighten the extremities. Sometimes the condition is more severe, and if they have a 3-ray foot or less, many of these children are treated with amputation. We do a foot ablation procedure and straighten the tibia, correct the genu valgum, and these children do quite well with prosthetic management. This is typically done at a young age. If you can, you talk to the families and kind of lay out the treatment options, and if they buy into an amputation strategy, this is done around a year of age. Our hospital is known for its prosthetic care. We provide prosthetic devices, again, free of charge to these children up to age 21. And so these children are managed very well with prosthetic care. These kids are very active. They're integrated into their school sports programs. Especially the below knee kids do quite well. Femoral deficiencies are also fairly rare. Here's a child with a fairly extensive femoral deficiency. The bone you see on the right that's in the socket is not her femur, that's her tibia. And so you see a very small segment of bone at the hip joint, and that's what she has for her femoral component. These can be variable in nature. You can see mild femoral deficiency, which can be managed without prosthetic management. Or more severe ones like this, there's no chance of lengthening or making that femur and hip normal, so we use a prosthetic management strategy for these children. Limb lengthening is a strategy for children with leg length discrepancy. Some of the congenital deformities or the limb deficiencies can be managed with limb lengthening. The traditional method of limb lengthening involved the use of an external fixator, or frame is what we call it. So you basically put this frame on and under letter B there, perform a corticotomy or cut across the bone, And then the frame can be driven and advanced slowly and distracted, usually about 1 millimeter per day. And as the bone is distracted, it basically kind of begins to regenerate and form new bone. And so that slow process of the bone healing and reforming and then basically stretching gives us gain on the length of the segment. There are limitations to how much you can lengthen in one setting. Typically, the recommendation is anywhere from 15 to 20% of the intact length of the bone is a safe measure. You can do this repeatedly if necessary. You can do a lengthening, have them heal, come back several years later and do a repeat lengthening if necessary. This is just what the regenerate looks like here. It's not adequate bone yet, but over time that begins to develop cortex and become strong again. These are very challenging procedures because you're not just stretching the bone, you're stretching the soft tissues, you're stretching the vessels, you're stretching the nerves. Any stretch on the long bone creates stress at the joint above and below, so you're creating stiffness and contracture. So it takes a lot of therapy, a lot of patience. You can imagine as an adult tolerating this, but maybe a 6-year-old is not going to tolerate it so well. So these are challenging, but they are options for children who have manageable deformities. The new device for limb lengthening is the magnetic nail. If you were here yesterday, Dr. Samdani talked about the magnetic rods in the spine. Same principles apply in the lengthening nail. There's a magnet here inside the nail. So you create a corticotomy, put the nail down, and then with an external device that's placed on the limb several times a day, it basically drives the male and female ends of the nail apart. And so again, you can gain several centimeters of length. The magnitude of length is about 8 centimeters currently for the most you can get with the nail. And again, some kids need more than that. If they need 20 centimeters, then they're looking at 2 to 3 procedures in their growing years. But this is a true advance in our technology, which has been taken care of here recently, and I think this is by far the preferred method of lengthening over the external fixators in today's management of these conditions. Developmental dysplasia of the hip is a common condition that newborns present with. We think this is related to multiple factors: first pregnancies, large baby, low amniotic fluid, breech presentation, history of DDH in the mother. The hip can be unstable at birth. It can be dislocated completely, or it can be just unstable. You can drive it out. Ultrasound is the best method for determining the position of the hip in the newborn. If it's not repositioned early, then the x-rays demonstrate what kind of long-term hip dislocation looks like. The film on the left is a left hip dislocation, and the film on the right is a bilateral hip dislocation. These children can present fairly normal. She's got a few changes in her gait. She's got some increased lumbar lordosis, a little bit anterior pelvic tilt, but she looks like a pretty active 4 or 5-year-old and doing pretty well. So if this is not caught early, many times it's caught late, which it's a little bit more of a challenge to correct. When you catch it early and the hip's unstable, we use the harness. It's a Paediatric harness, which is just promotes an improved position of the hip. This device is usually worn for 6 to 8 weeks. Many hips respond to harness treatment early. If the harness should fail, it's successful 75–80% of the time. If the harness should fail, we move to casting, where we put the baby asleep, do a what's called a hip arthrogram. We put some dye in the hip joint so we can actually see the hip reduce, and then place them to this hip spica cast. That's worn typically for about 6 weeks and then changed to an additional cast for another 6 weeks. If that should fail, we have some operative techniques. Hip arthroscopy can be performed in a newborn. It's challenging because the anatomy is so small, but you can look in the hip and see what the impediments to reduction are and clean the hip out, affording some stability to the hip. If that should fail, then we move to our more reconstructive options, where we do actual open procedures on the hip joint, remove the impediments to the reduction. Typically have to shorten the thigh bone just a little bit to take the tension off the hip. We rebuild the hip socket. You can put bone graft here in the hip socket from this position here. Make sure the hip's in, tighten up the hip capsule, put a cast on for about 6 weeks. This works. More complications involved. You can have AVN, or avascular necrosis of the hip, infection, wound problems, cast problems. So if we can catch it early, we're much happier with that scenario. So this young lady's 15. Can I call on somebody? Everybody want to take a stab at the x-rays? Yeah. Anybody can chime in. Yes, sir.
Is the left hip a little bit elevated, like the socket?
Okay.
It's a bit dislocated.
Yeah, I'd say it's a bit dislocated. Anybody else? So hip sockets are right here. Uh-oh, how'd I do that? Hip socket here, hip socket here, femoral head here, femoral head here. See that? So bilateral full dislocations of both hips in a fairly older child. Now, what would you think the natural history of this would be? Good, bad, medium? Any guess? Bad. So how long do you think her hip's going to last before it becomes painful? Not long? Yeah, interestingly, these hips tend to last about 50 years. Despite being dislocated and despite ambulating like she is, they tend to do pretty well. So we don't try to reconstruct these. Our procedure to try to reconstruct these would create more problems than she's going to experience. And so if you see these late, we just let them go and let the total hip surgeons deal with them later. Kind of moving around the extremity, we see metabolic bone disease, so calcium, phosphorus metabolism, if it's out of whack. You can see changes in the growth centers. Growth center changes lead to deformity, and so this child has fairly pronounced genu varum. In a growing child, we can take advantage of the remaining growth. So we can take advantage of these growth centers here, and we can manipulate those growth centers. So we tether the growth either with plates and screws or a single screw. And over time, the limbs begin to grow back into a straight mechanical axis. This is a fairly easy procedure, well tolerated, and fairly predictable. So if they've got remaining growth, a lot easier to take care of. Older children, when they don't have remaining growth and big deformities, then we've got to talk about more surgeries. So these children can present late with genu varum or the knees that bowed out. The treatment for those is usually osteotomy. We can do those with plates. Usually we use external fixators, so if they're short and they need a little bit of length, we can add the length necessary. We usually do these if they're bilateral in a staged fashion, but you can see this child does very well with correction of her alignment. We have a motion analysis lab at our center, which is a tool we use for diagnosing children with gait issues, for determining treatment plans, for research. So a lot of our kids, if we do gait improvement surgery we evaluate them in our lab. It uses motion capture cameras, small little reflector bulbs on specific bony areas on the body, computers, force plates, foot pressure analysis system, EMG. We get x-rays, and then we meet as a team to go over the data to lay out a treatment plan. It's a very useful tool. Proud to say that Shriners Hospital has the most motion labs in North America. The gait analysis gives us very meaningful data on all the segments of gait, what determines normal gait, and how there are deviations in the gait cycle. So it generates this computer model of the gait, and then it generates data which we can look at and compare to normal. It analyzes and isolates specific segments of the lower extremity, so we can look at the ankle, the knee, the hip. We can look at what the pelvis and trunk are doing in all three planes. So we have sagittal plane alignment, we have coronal plane alignment, as well as transverse plane alignment. We can measure the forces that are going across the joint. So we can measure the stresses and the moments and the powers and the torques. All of that gives us data and information to lay out treatment analysis for or treatments so that we can make a good plan for treatment for the children. So this is a young lady. She has a condition called cerebral palsy. It involves mainly her left lower extremity and her left upper extremity, so it's a hemiplegic type pattern. And as you can see, when she walks, her left foot is turning in. She has some slight flexion of the knee. When she lands, her foot's landing on the lateral border of the foot. She has some asymmetry in her upper extremity motion. We can do the gait analysis and really kind of uncover what's going on. So at the ankle, we see that there's, just for convention, the blue is the left lower extremity and the red is the right. So she's got an internal foot progression angle, meaning the foot's turning in. She's got a lot of that internal rotation coming from the hip. So that directs us toward where we need to do our correction. We see a little bit of lack of extension at the knee, and we see some disruption in our ankle curve. So these types of data plots and informations help us determine where the deviations are coming forward and laying out a good surgical treatment plan. So for her, she underwent some foot and ankle surgery to get the foot plantigrade. We did a little bit of lengthening of the muscles behind the knee, and then we rotated her thigh bone. So we did a procedure to correct that internal hip rotation so that her knee's pointing in a more normal fashion. And now she has a fairly symmetric gait, which is what we like to see after these types of analysis. So that's just a little bit of taste of what lower extremity pediatric orthopedics and upper extremity pediatric orthopedics looks like. So I want to divert a little bit to management of clubfoot and just kind of talk about the historical nature of our clubfoot management, which has been very interesting over the past years. So clubfoot's the most common pediatric foot deformity that we see. It's called talipes equinovarus. It has specific deformities that we see. If you remember the mnemonic CAVE, C-A-V-E, C is for cavus. That means the foot is plantar flexed and it has like a high arch. The A is for adductus. It's internally rotated. The V is for varus, where the hind foot is rotated inward. And the E is for equinus, and so it's plantar flexed. And almost all club feet have those deformities. Clubfoot is commonly diagnosed prenatally. Many in the States, almost all pregnant ladies get an ultrasound at 20 weeks. And many of our technicians and our sonographers are very good and adept at seeing clubfoot deformity on the scans. So here you can see several images of what the clubfoot would look like prenatally. It doesn't really change our management, it just helps prepare the family. We do see these families prenatally at our hospital. We'll offer them consultation. Just give them some education and kind of about what to expect as far as treatment goes once the baby's here. Untreated clubfoot is problematic. If you have an untreated clubfoot, which was very common in the developing world, these feet tend to stay turned inward. They begin to walk on the backs of the feet. It makes it difficult for shoe wear. The back of the foot is not designed to bear weight, so that tissue becomes thickened and calloused. A lot of times they develop this large bursa, which is very painful and very challenging for these older patients without treatment. If you think about the treatment of clubfoot, it goes back, way back. So back in the ancient days, there's Egyptian hieroglyphics showing signs of clubfoot deformity. So we know clubfoot's been around for thousands of years. Some speculate that King Tut also had clubfoot deformity based on, I'm not sure how they did that, but they figured out, I guess, from his mummy or whatever, but they determined that he may have had some foot deformity, and some speculate that it was clubfoot. Over the years, there have been paintings and artistry pointing to deformity. This was a Spanish painting in 1642 entitled The Clubfoot Boy. So it's been around a long time. Treatment's also been around a long time. So our ancient father of medicine, Hippocrates, described methods of bandaging the foot and strapping the foot, trying to afford a correction just with simple non-operative means. In the 1700s, 1800s, there were descriptions of devices, external braces, to try and afford a better position of the foot deformity. Again, nothing operative was done, no casting. It was basically just kind of strapping these devices on and trying to tension the device to improve the foot shape. The early reports of surgery for clubfoot involved lengthening of the heel cord. And so this was probably done without anesthesia, without any antisepsis, and then putting this ratcheting device on the foot to try to stretch the foot into a better position. Over the years, devices were developed. This was the Thomas wrench. So you basically grab the foot, create a long lever, and try to stretch the foot into a better position. More force, more stress, more injury to the foot, more damage to the joints, more stiffness, more pain. Not good. So other options were manipulation over these blocks of wood. So again, just using more force, more more energy to try to correct the foot deformity. This looks painful. I don't know if you think that or not, but this looks pretty painful to everybody involved. You know, using these long levers to try to crank the foot into a better position. So in the mid-1800s, that's when we began to see surgery advance. There were developments of aseptic technique to reduce infection. 1890s, we developed the ability to get x-rays of the foot so we could actually look at the bony alignment of the foot. And then in 1900s, started using tourniquets to limit blood loss. And so the 20th century saw really kind of two camps of treatment for the club foot. There was an operative approach. There were a lot of surgeons who advanced the idea of surgery for club foot deformity. They thought, okay, if we can take apart the foot, we can restore the normal anatomy, and we can align the joints, and the foot will function normally. And so there were many opinions and many thoughts on, you know, what incision do you make? Do you make a midline medial incision? Do you go from the back? Do you use pins? Do you not use pins? How much surgery do you need to do to get a good result? And so there were many enthusiasts for operations for club foot. There was a second camp of people that recommended a non-operative approach. They felt that surgery was going to lead to poor outcomes, that when you do surgery, it causes stiffness and scarring of the foot. You can achieve a similar correction with slow, gradual stretching. You can manipulate the foot, cast it, and this helps preserve the joints, eliminates the scar tissue, and you would have better long-term outcomes. And so really in the 20th century, really from about 1950 to 1980, there was this battle between groups of surgeons and groups of other orthopedists. Some said do surgery, some said do casting. It became apparent in the 1990s that the long-term results of surgery were not as good as we anticipated. There were some good long-term studies 30 and 40 years out from surgery for clubfoot that showed many of those feet, especially if they'd had multiple surgeries, were having pain, or having stiffness, having arthritis, and those feet were not doing so well. And so this man was very prominent in the movement for non-operative management. This is Dr. Poncetti. He was in Iowa, and he was born in Spain, and he was a medic in the Spanish Civil War. He completed his medical training in Spain, and then he ended up in the States in Iowa, which is a state in the central United States, kind of known for its cornfields and farmland, and ended up practicing there for years. And when he got to his residency, one of his mentors asked him to review the results of clubfoot management, because they had noticed that the surgery for the clubfoot deformity, the results just weren't quite as good as they wanted them to. And so he began to review the results. He did some studies looking at the long-term results. He did some anatomic studies looking at the deformity itself. And he began developing his own method for clubfoot correction. And this was like in 1950 or so. You know, there's some things in medicine that change very, very slowly. But there's other things that have been major paradigm shifts. For instance, you know, when Dr. Salk invented the polio, or discovered the polio vaccine, that was a game changer for children with polio. When Alexander Fleming discovered penicillin, that was a game changer for infection. And this gentleman really changed the total course of management for clubfoot deformity. In 1963, about 10 years after he began using this method, he performed he wrote his first paper on clubfoot management. And you would think that, okay, great, this guy has developed a method and it's working. You would think it would be accepted by the medical community, but unfortunately it was not. It was basically rejected. Many said, no, it's just your population. They're mild club feet. They all do well regardless of what you do for them. It doesn't apply to all club feet. And so he was really criticized and ridiculed by the orthopedic community about his method. He retired in 1984, so late 80s. People were still doing clubfoot surgery. They had not adopted his method. And he retired, and then he realized, okay, the only people using his method were the people that he had trained at his institution. Nobody else has adopted it. So he came out of retirement. He wrote a book. He did some more papers. And really tried to promote his method. And the biggest thing that promoted his method was the internet. What was happening is the mothers of children who had his method of treatment were getting online. They were getting on chat rooms. They were getting on social media sites. You are probably all too young to remember Yahoo groups. Okay, that was our time. But they were getting on these groups and talking about how this method was so successful. The feet were great. The feet were flexible. And that's what really stirred the movement to accepting his method. And so when the mom comes to me and says, okay, I want you to do the Ponseti method for clubfoot management, you kind of have to do that. You got to do what the mom says. So, but that was the change. And really it boiled down to knowing how to manipulate the foot, putting on cast, stretching the foot gently, and affording a good correction. It's just a simple video showing the method. It's fairly simple. It's easy to learn. There are courses that teach you the method, or you can just learn from someone that's been trained in the method. It usually takes two people to do it, one to hold the foot and manipulate the foot, and the other to wrap on the cast. These are long leg casts. We tend to use plaster. It's easier to mold and to hold the foot with the plaster. You can use fiberglass if that's all you have. These are done in the outpatient setting. You basically just gently stretch the foot. If you remember, I said the deformities of the clubfoot are cavus, adductus, varus, equinus, and that's the order you do the correction. So you correct the cavus first, and then the adductus, and then the varus, and then lastly the equinus. The equinus is corrected with a percutaneous heel cord tenotomy. We basically transect the heel cord. We do 5 to 6 weeks of cast, and then under some local anesthetic, the heel cord can be transected, and that affords correction of the equinus deformity. And these babies who are 1, 2, and 3 months of age, the heel cord scars back together very predictably. You don't want to have a heel cord tenotomy in an adult. But in kids and babies, this is a very safe procedure to do. This is done in the clinic under some local anesthetic. The children tolerate it very well. And so the foot's now corrected. You put it in a last cast, which holds the position. Leave that on for about 3 weeks, and then the correction is complete.
So you sever it completely and then it heals back?
That's correct.
Wow.
Yeah. So you can pound. It's a small little what's called a beaver blade. Kind of poke in, feel the tendon, cut the tendon completely. You'll feel a pop or hear a pop, and then the foot dorsiflexes readily. So once the foot's corrected, you have to maintain the correction. So this is a what's called a Dennis Brown bar. There's multiple devices now that work for keeping the foot stretched, externally rotated. Child wears this for about 3 months full time, and then nights and naps till about age 4. So there's a big commitment to long-term bracing to prevent any recurrence or relapse. So if you look at the data from about 96 to 2006, you can see the dramatic drop in the number of surgeries that were done for clubfoot deformity. When I did my fellowship in 2000, we were still doing probably 1 clubfoot surgery a week. One or 2, sometimes bilateral cases. And I'd say currently in our practice, it's probably 1 a year. And so it's dramatically changed how we manage clubfoot deformity. The nice thing about clubfoot is it can be done not just in the States or in the developing world, but in the developing world as well. We still see patients who have had neglected clubfoot deformity, but the procedure and the casting method can be taught. Many of the countries have trained physiotherapists, not just MDs and surgeons to do this, but other medical support people to perform the method and maintain the correction. Training centers are everywhere now across the world. Many centers and groups have taken charge and want to see management of clubfoot change for the entire world. So this is just Uganda. Uganda didn't have any clubfoot management prior to 2000, and then 10 years later you see all these treatment centers pop up who are managing clubfoot adequately. So it's been a worldwide phenomenon on how we manage clubfoot, all thanks to Dr. Ponseti. So again, clubfoot, common deformity, casting's the way to go, long-term bracing to prevent any recurrence. I think that's all I have. So I have